HCG. Kothari sir back again on the stage as a surgeon. Dr. Indu Ambolikar from Mumbai and Dr. Bharti Devdani from Jodhpur. So we have radiation oncologists, medical oncologists and surgical oncologists.
Okay, time 30.
So radiation is definitely...
Okay, great. It's a great time. Okay, I think things are changing now. There was a time when the surgeon was the only thing for cure now. But now looking at this topic, the surgeon seems to be destroying the quality of life of patients. So it's a difficult time. So, so when I come on the stage here after all this debate, my only concept is I remember the song by Biggie, Staying Alive, Staying Alive. Okay, and that's not only for the patient, it's for me as well. Okay, so the whole idea of this treatment for rectal cancer was to improve survival. If you could improve survival, then you could do sphincter surgery. And then you could look at functional outcome, the LAR score, the urinary and sexual function. And now everyone started with this goal, and suddenly survival has gone off and organ preservation has come in a big way. I think what Anand thought was the exactly right thing. We are basing everything on the West. So the TNT trials, the whole basis was that local recurrence is less than 5%. I wish, okay, because I work in TMH and I see patients from all strata of society, the lower one as well. And less than 5%, believe me, it's not there. Second thing, if you say you get complete response by the international database, you would say local recurrence would be less than 2%, systemic recurrence is of less than 10%, no adjuvant chemotherapy. If you look at data from India for complete responders, I'm sorry to say, local recurrences even in complete responders is 8%, systemic recurrence is 30%. So jumping on a bandwagon and to have complete thing and organ preservation may not work till we have the data. But let's go into this and see how things go. But we are all entitled to our views, and let's see how things go. So I think I have 4 cases to run through. So we have already done a lot of debate. The first one is about what regimen to do, and everyone will have his plans and things like this. So let's go through this. Okay, so this is a 65-year-old lady who comes with altered bleeding habit. Tumor is 4 centimeter from the anal verge. Vonices are not involved. Long segment tumor, 4 to 8 centimeter, moderately differentiated adenocarcinoma. It's non-metastatic. So MRI looks like a low rectal growth infiltrating the mesorectum, multiple mesorectal nodes involved. So our plan would be, so surgeons, Dr. Kothari, all others are medical oncologists or? The 65-year-old lady, looks like...
So the workup is still pending in terms of, I would like to...
Metastatic colonoscopy, all that, no other metastatic disease.
So we are now looking at this loco-regional disease for the further management. So we're just thinking,
would anyone want to go for upfront surgery for this? Would someone want to give, what other sort of neoadjuvant therapy? So
yeah,
everyone is a medical oncologist.
You're
a surgeon? Medical oncologist, great, awesome.
I'm concerned that, 12 o'clock, and it is mentioned that CRM is threatened, so, and multiple mesorectal nodes. So for sure, neoadjuvant treatment is required. Neoadjuvant chemoradiation is what is required. So that's what we.
So you would go practice for long course, or you want to go for?
Yeah, we practice at our institute long course.
Okay, a medical oncologist.
So I feel this patient should go for neoadjuvant approach and neoadjuvant CTRT, followed by assessment for surgery. So I think neoadjuvant CTRT.
Okay, madam.
Yes, sir. I would go with long course standard fractionation chemo RT followed by surgical assessment.
Okay.
Sir, it's open for discussion because it's CRM threatened. There are multiple
you
nodes.
have to tell your views. So we've seen the views of everyone. It's nothing right or wrong. You see, finally at the end of the survival for everyone is the same.
Mostly as of now, it's still long course.
Long course, okay. So I think...
Another reason I would say long course, you said it is a 4 centimeters from the anal.
That's right.
And intersphincter...
4 centimeter from the anal verge, intersphincter plane is free. Circumferential, long length tumor.
Intersphincter
Long
base is few.
still maintained, right?
It's still maintained.
It's still maintained. So there is one more reason I would like to give long course radiation, because I am looking forward that I am going to consider intersphincteric dissection in this patient.
So I think we ought to look at the age also for all these patients. Again, if you look at our patients, they are younger, 40, 45 or something, and not like the 60. Now this is a 65-year-old lady, so would you want to give additional chemotherapy for this one? So I think the panel is absolutely right. So it's a case-by-case discussion, and we see how we go for that. Would you intensify treatment by giving TNT? Would anyone want to give after consolidation, whatever, after chemo radiation, would you want to give any additional chemotherapy, suppose if there was no response? So we know we can't do upfront surgery. Obviously, the local recurrences will be quite high there. So we will give either neoadjuvant or total neoadjuvant therapy. So like what I said, local recurrence is still a problem. So we won't jump into that. Okay.
So as you are asking, after completion of neoadjuvant chemoradiation, my tolerance is 12 weeks that I can do surgery. And as I am repeating that, I am still looking at 65 years of age. I'm little skeptical about that number, but at the same time I am still looking for sphincter preservation in this patient. And another strategy that we have, that while I'm waiting for that time, we'll give consolidation chemotherapy to this patient.
Okay, anyone else wants to go for it? Or?
Yeah, so regarding the induction chemotherapy, so basically if we are planning TNT approach, I mean NSCTRT approach. So looking to her age, I think the choice of chemotherapy makes a difference. At 65 years of age, sometimes we see comorbidities also. So the tolerance of chemotherapy is going to be very important. When we are talking about the long course radiation, then I would be more comfortable with giving capecitabine along with radiation. And maybe followed by the chemotherapy, again, whether it is K-pox or FOLFOX, again, it depends on the tolerance.
So that's a very good debate. So you see, all these things about TNT, you are improving the outcome of good responders. So they were already responding and you gave them chemotherapy and you said you got complete response. So you instead of starting TNT at 2 weeks, why don't you start at 6 weeks? 15-20% have already got complete response. And then you don't want to give them chemotherapy. Sorted. You identified poor responders who have not responded. So all those, if you intensify treatment, they are not going to benefit. We have data who 6 weeks were MRF removed positive. We give chemotherapy, it's not benefiting. So why do you want to start immediately? Come at 6 weeks. If they're responding, let me go back to this paper. Then you can give them consolidation chemotherapy. But hang on. What is the data? Now look at this, was the initial start for starting TNT, giving FOLFOX, the Garcia-Aguilar paper. So they gave 2, 4, 6 cycles of chemotherapy and increased complete response to 38%. But is it only because of chemotherapy? Is it or because of waiting? Now if you look at OPRA study, that was looking at chemotherapy before or chemotherapy after consolidation. The time difference between consolidation chemotherapy was of course longer. So the time difference itself made a lot of difference there. So what my proposal would be, you have a look at 6 weeks or so. What do you agree, Dr. Kothari?
Yeah, it's very important point.
Would 4 weeks make a difference starting TNT before or not? So you can avoid chemotherapy. Why give 15% people additional chemotherapy? They're getting complete response anyway. You're not going to give chemotherapy for complete responders, at least based on the data. There is no right or wrong. You may give, but do you think there will be any advantage of delaying chemotherapy by 4 weeks? It is just a question to think about.
Now, in this particular patient, if you are asking me that am I going to change decision at 6 weeks? No, because advanced looking disease, multiple mesorectal nodes, so I am not going to take a chance, because even though it looks like that it is having a complete response, which should be in the rectum, but what about the nodes?
Right.
They are,
so I think she is going to go for surgery. She's responded, then she will definitely go for that. So we already know about Rapido. We have already discussed that. So they looked at mainly high-risk patients, T4 and 2 lateral pelvic nodes and MRF positive. Disease-related treatment failure was 7.5%, but no difference in survival. Why give chemotherapy for all these patients? You can give them, you can salvage them in chemotherapy when they have recurrence. So that would be my take on it. For benefit of 7.5%, would you give chemotherapy to 92.5, or also in the Rapido, 50% of the patients in the standard arm did not receive chemotherapy. So the benefit may be because of that. I have to say I was a reviewer and endorsed this paper for Rapido as well. Prodigio, again, same thing, 7.5% DFS benefit, but FOLFIRINOX may be more aggressive. We'll go quickly. We already know consolidation is better than this one. Most of us are thinking about consolidation chemotherapy. So Dr. Kothari, so now suppose if you say this for the younger patient and you wanted to give them TNT, so would you think, I know your protocol is that 4 weeks CA with no toxicity, I agree with that. So let me come to the radiation oncologist. So suppose you think this is a candidate for TNT therapy, so would you give them consolidation chemotherapy after your radiation, like short course RT and chemo or something, or
So that can be considered, because if Rapido has taken more advanced diseases instead of that, and maybe that's the cohort we see.
So would you prefer induction chemotherapy or consolidation? Based on all the things that have come out.
Maybe in the short course followed by chemo
Consolidation. Madam?
Sir, I still feel that long course chemo radiation should be given, because this is very advanced disease, and although in Rapido chemo was given, but many of patients like the previous 65-year-old lady was there. If suppose she will not be able to tolerate chemotherapy, at least the radiation benefit should be given with the long course chemo radiation. And we should not forget German trial also, where the local recurrences were decreased to 1/3. So we cannot get away with the radiation. And
Is Rama here or Rama's left today?
Chemo radiation.
Ramakrishnan here?
Yeah, he left.
Okay, Viraj. So suppose if you were to do consolidation for a younger patient. Oh, Rama is here. Rama, you prefer consolidation chemotherapy. So would you want to give short course and consolidation chemo, or long course or consolidation chemo? Because we know consolidation is better than induction therapy based on all the other studies.
I don't think there is any direct head-to-head comparison between the two. We are actually doing a trial at the institute comparing short course, the Rapido protocol versus the OPRO protocol. But I would choose short course in an elderly patient. Like the first patient that you described, it was only a small focus of anterior CRM involvement, which was quite high up according to the MRI. So for those kind of patients, I think a short course followed by consolidation chemo should be sufficient.
So I think all experts think alike. So the low tumors which are anterior have the worst outcome. The Mercury study showed the same, and that is very good to have a panel like this, experts. So we know, suppose if you were to intensify treatment, then you could do either for these low anterior tumors, you can either do that with radiation itself with boost or by giving chemotherapy. But so we don't have any data of short course and consolidation chemo versus long course and consolidation. There are 3 ongoing trials and which will shed light on this topic. Stellar, I think there was a conflicting school of thoughts between Stellar and Rapido with regards to DFS and OS, so the jury is still out. We do a lot of patients with short course radiotherapy. What we found, when with short course and consolidation versus long course, we looked at functional outcomes. Because the planes get a bit obliterated if you're doing a sphincter preserving surgery, the functional outcomes are not that good. Complication rates were similar. So the low anterior resection syndromes are slightly higher in the short course. I think it's accepted in DCR. So for younger patients, if you wanted to give short course RT and chemo, then look out for functional outcomes. So that is very important. So but things have changed. I think ESMO and NCSCN are both. But here, this is the real life situation, and we keep on forgetting. We send them for radiotherapy, dates are a bit long, and they sometimes end up with a sandwich protocol. Someone has received 3 cycles of chemotherapy because they saw TNT, and they said chemo radiation is very long, so give short course. And then now there is no data on this sandwich chemo radiation protocol. But this is what happens in India. You have to be very careful. What will be happening? People will be having chemo, then 2 cycles toxicity, then radiation. There are no dates. So nightmare. Okay, so no data. Okay, so the real life situation, I think for India maybe trials more than that. The real life situation what we see may be better. So anyway, we did surgery for her, LAR with covering ileostomy. So but then if you look at it, TRG is 4/5, margins are free and nodes are still positive. So she received TNT of some form, but is this what you wanted? Not very sure. So we have to judge very carefully. I think what the panel totally said, maybe long course radiation would be there, but then logistics is an issue. So sometimes you have to go mish and mass, and we sometimes use data to suit our practice. So if you say, okay, we have long dates for radiotherapy, why not put them into the list? But suppose if we are an affordable country, then we can do it. Okay, so that was good.
Okay. So everybody agrees short course causes more problem after surgery?
I to feel,
unanimously.
I'm not sure the surgeons in the...
No, my surgeon definitely feels. No?
Somehow.
No, functional outcome.
Yeah,
no
so
complication wise.
I'm talking functional outcomes. Lot of LAR syndromes.
somehow our experience, we have tried for last 7 years. Anecdotally, we tried and have done about 20 cases on short course, and somehow, one way or the other, complication rate was higher after short course, and that's how it's probably my fear that I don't now subject my patient to short course. I'm sure that the way it is being practiced, there could be something wrong with the way probably we are dealing,
one
actually.
comment from radiation point for short course. For short course also today's time it should be IMRT, the plan, because there are published guidelines for that from UK. You have to respect the bowel and bladder doses. There are given constraints for that. So even if you're doing 5x5, it has to be IMRT. Especially the kind of cohort we see, we need to extend till external iliac and cover inguinal. So IMRT becomes very, very important in that. Second is, I feel, and I quite like Madam's idea, we know it from wrong since we are working, that if I just compare the radiation biological equivalent dose, a long course and short, what we are doing till now is not comparable. Rather, a 13/5 is reaches, Madam correct me if I'm wrong, reaches a similar biological equivalent dose. So maybe that is more a better approach to see later on what happens in the long term. Because 25 in 5 and 15/25 is still not comparable. So we are relying more on chemo in that, because that might compensate of less biological equivalent.
So I think
dose.
geographically differences is there in surgeons. If you look at Sloan Kettering, they always in opera they use long course chemo radiation. The Rapido, the Dutch one. No. I know. But if you look at French as well, you see they are still not doing much of short course. They give you fall first. No, even the French is a national system. The Dutch would prefer short course. Rama, okay, we have to go on to the next case after this. Yeah.
They don't have 5 fractions.
Yeah, Ram.
Even in published literature, more leaks were there.
P.
Were there more leaks,
He
sir?
also did not show increased
outcomes,
complications in the short course followed by delayed surgery arm. So
And the complications don't change if you do enough, but the preliminary data of Rapido had shown more MRF positivity in the Rapido. Okay, but let's not go into. Let's go to the next case now. So I think everyone has their preferences and whatever they get comfortable with. Functional outcomes. I think even for morbidities, Rama, things didn't change. When we looked at LAR score, then the outcome looks slightly different. Okay, let's go to another one quickly. 60-year-old female, really good cancer, 4 centimeters from the anal verge, looks mobile, not amenable for TEU or TEMS. CA done, CT scan is non-metastatic and this looks okay. So, would anyone want to give neoadjuvant therapy? Let me see the patient. You are a big man in the hospital. I will come to Dr. Kothari later. Yeah, sure. Intersphincteric space is free, sir. And it's a 4 centimeter just above the levator thing. So if it requires intersphincteric. So now I think you are the dominant force in your hospital. All patients come to you. You are a radiation oncologist. What do you want to do? It's T2, N0, 60-year-old.
ISR is possible here.
ISR is possible.
No, so no decision by me. It should be everybody present in that.
No,
That's
you
the
are,
first dictum.
You are working.
We are very hospitable people, radiation oncologists.
What do you think, madam? So do you want to give neoadjuvant therapy? My radiation oncologist will push me
I
to.
was just remembering about that quadri silver trial. It should be it should be true to T2.
It's 2-2. I can confirm. I've done endoscopy.
Then I think surgery upfront.
My heart is set on surgery. List is already fixed.
Surgery can be upfront.
Okay, madam, do you want to give chemotherapy for this one?
We can.
Yes.
We can avoid surgery.
Okay. Okay, good.
I want to ask surgeon, what is the stoma chance for this? Based on that, I decide.
I can give you a different answer. Let's finish the round. I'll come back.
I mean, I could not understand. You said, Reena, that you want to ask your patient that.
This is how I would counsel that yes, ISR can be done, surgery is the standard, but there is also there's an alternative modality where you have chance of more than 75% of not requiring surgery. But there will be a chance 25%. So you will
What's the next slide, Karan?
So you will require to then give over 25 radiation. But there's a chance of 25%
Yeah, Reena, we'll come back. We'll come back to it. Great.
I am
So,
preserving sphincter in this patient.
yeah. But sometimes, if you think she's 60 and you don't want to look at a functional outcome, would anyone want to do an APR in the crowd versus ISR?
No, not APR. And number two is T2N0 requires only one modality for the cure, and sphincter preservation is done. So
We'll come back to that, Reena. Okay, that's good. So, okay, what approach would you like? Would you like to do it open, laparoscopic, or robotic? It's very
clearly only robotic. I'm talking about a tumor at 4 centimeters, so ISR, and with
Next
my
slide, please.
experience,
Yeah.
I have seen this.
So definitely, I think for the approach for low thing, boss next slide karenge. So these are the two options, and that would be a thing you have to discuss with the patient. If they feel, I wouldn't take Professor Sugarbaker's comment and say if you're homebound, then you do ISR or something. Discuss with the patient. APR may be a thing if he's totally incontinent, nothing. But ISR, patient underwent a robotic ISR, and that was okay. But then there are other schools of thought. So, boss, is pe click karenge. So whether you do lap or robotic, that is still a thing. I think obviously with robotic approach, what do you feel are the advantages, Dr. Kothari, for going for a robotic approach for intersphincteric resection?
Yeah, because I can go into the pelvis, and with this robotic I have definite advantage that with this particular situation I'll be able to go around, and my dissection intersphincteric area which I am concerned can be definitely done better. I mean, my personal preference.
Definitely.
You can definitely
I mean,
do
it is definitely can go down in the plane and get dissected. But even after doing this dissection, there will be functional abnormalities there. And we have tried to compare robotic versus lap in terms of functional outcomes itself. So, but that discussing this with the patient is very important before we do intersphincteric resection, because sometimes they come back with problems, and sometimes they need to do a stoma therapist before itself. So they need to turn about rectal irrigation and things like that. So the other thing, if you're looking at functional outcomes for this for an older patient, not in routine practice, but as a part of trial in an administrated thing, then you can think of other things. There are a lot of trials which have come for this T2 rectal cancer. What's next slide karenge? So next slide, please. So we know you can give radiation to these patients, and you can have complete response rates of 50 to 56%. And if it is less than T2, if this was an old patient who was totally unfit and you wanted to give from the radiation, or someone asked you, they said, okay, there is a 56% chance he may have a complete response, and the local regrowth can be less. Here I was just looking at this one. Next one, boss. So we compared robotic versus laparoscopic. We included those patients where continence level was okay, but surprisingly, while we still believe in robotic, the functional outcomes, we didn't find much difference in this. These were all assisted people with this one. So means sometimes what you believe in, I really believed in this way because perineal part of dissection will be less. We did quite a few, but it is still there. Boss, next slide, please. So, okay, next slide. So we know even for T2 tumors in unfit patients you can do, and we know if they're early tumors and you give chemoradiation, the local regrowth rate can be less than 3%. So it can be an option, but you have to remember, young people, they're going to live long, so 45, 65 years long-term effect of radiation can be there. There can be second primaries there, so choose well. Next slide. So there are a lot of trials. Most of these were phase 2 studies, the ACUSAC study and the TREC study. And what it shows was, in the TREC study, they used short course and delayed surgery, and they saw 70% case it could have organ preservation. Next slide, please. There is a STAR-TREC study which is trying to compare this T2 for TEMS versus short course and delayed surgery or long course. Again, the organ preservation looks okay. Next slide. But a word of caution. So you can see for all this organ preservation cards for the Dutch study, ACUSAC was the American study, all for T2 or T3A sort of thing. They were all phase 2. The GRECA2 was the only trial which compared it, and it seems to be slightly okay. But the problem was there, if you look at the paper for GRECA2, next slide please. There is a 4% mortality during chemoradiation in the CART study. So a patient who didn't require chemoradiation, there was a mortality there. So sometimes over-treating people can be difficult. So you have to counsel them really well there. Also, if you look at the study where, the TREC study where they try to do, or the GRECA study itself, when they did local excision after chemoradiation in this patient, they managed to do organ preservation, But those who still came positive and required TME, their complication rates were high. So you have to be careful. So if they're going to respond, those people are okay, the quality of life is there. But on the other hand, if you don't respond, sometimes the sphincter preserving surgery, it was T2, if you did local excision, it might end up with an APR. So you have to think at lot of things there. So I think we are changing from testosterone driven surgeons to thinking, so you're thinking about it all the time. Good, next slide please. Okay, next one, lateral pelvic node. So suppose, Dr. Kothari, a question to you. 30-year-old man comes, a tumor is 6 centimeter from the anal much mobile, you can operate. Next slide, please. And you just find a 8 millimeter size right obturator node. So CRM looks free, no mesorectal nodes, just an isolated lateral pelvic node. I mean, that can happen in about 8% cases. So would you, robotic, you are really good at this, and you think this, should you go for upfront surgery? I mean, this, I had this doubt in my mind because we do a lot of this. So would you?
No, N1 disease in a young gentleman, certainly I would like to give neoadjuvant.
Right, okay. Skill, with wisdom once over skill. Okay, let me ask the radiation oncologist.
So, sir, I would ask that whether that will be addressed in surgery or not. If not, then we need to boost
No, what do you
it.
think? Can you go for upfront surgery, or you would sit down and push your foot down? Won't neoadjuvant chemoradiation? Just one node, you can just, in 20 minutes, that node will be out with lateral pelvic node dissection.
Because, sir, it will require adjuvant. So instead, always it is better to be neoadjuvant.
So after
because
you
of
give
the node.
neoadjuvant therapy, you won't give adjuvant, or you'll still give, no?
Sorry, sir?
Go on. Madam, what do you think? You would think it's a systemic disease TNT protocol for the Rapido 1 lateral pelvic nodes are positive.
So I feel this patient should go for neoadjuvant approach first, and local control as well as the node positivity, there will be a chance of distant recurrence if we don't give aggressive neoadjuvant treatment. So I feel this patient should go for NACTRT followed by consolidation, chemotherapy, followed by assessment for surgery.
Okay.
This would be my approach.
Okay, that sounds good, but it looks like only T2 or something. But then be attempted. Sometimes you have this young patient, 30-year-old, not married, with children, want to give them radiotherapy. Bit difficult. So because you have all this situation, you will have 22-year-old girls who are going to get married in 4 weeks, and they come with surgery for all these patients. So would you give this one? Because so these are different. So this is a 30-year-old man not married. Okay, so you have to decide. So we thought about it, and then I actually, just like Rama, I wrote to Takashi Akiyoshi. Next, please. Next slide, please. Next slide. No, go back. So actually there is a lot of data from Japan, because they used to do a lot of upfront surgeries for even for lateral pelvic nodes, if not. So he actually searched data for even for T2, any of your lateral pelvic node, and he did bilateral pelvic node dissection surgery, the lateral recurrence rate was 30% or more. So sir did the right choice, chemoradiation for everything. Whether by giving additional consolidation therapy will it improve or not, the Rapido arm had about lateral pelvic nodes, so they gave short course and consolidation. But there were not many lateral pelvic node dissection done in either group. At least they didn't put in the study there. We asked the reviewers for papers. So we don't know how many people had lateral pelvic node dissection in group, because that may not have been standard of care at that point. So things change over a period of time. Now lateral pelvic node dissection is getting accepted, but when the trial was done, was it done? Lateral recurrences could have been because of that. So we don't know. A lot of things, when we go back in papers, you understand. Next slide, please. So now with the Ogura thing, the standard is if you have lateral pelvic nodes which are 7 mm, they go for neoadjuvant therapy, any sort of neoadjuvant therapy. After neoadjuvant therapy, you do an MRI again, obturator node is 6 mm, you do, or internal iliac is 4 mm, then you do lateral pelvic node dissection. The learning curve for lateral pelvic node dissection is at least 19 cases. In the earlier cases, almost we used to get 20% lateral recurrences, and they were very difficult to treat. You almost require uretic reimplantation, exentration, bleeding from iliac vessel. So if you're going to do it, you better do a good job, otherwise you're in trouble, because when I do salvage for these are really difficult. Next one, please. So anyway, received neoadjuvant chemoradiation, and we did lateral pelvic node dissection because the node was persistent, and the node still came positive. So after neoadjuvant therapy, it was still there. The Ogura paper showed that if you had all this accepted criteria, 7 and downstage, then there's a 50% chance of finding node positivity. Our positivity rate is 25%, so it's quite okay. Next slide, please. So learning curve is there. So if you are a high volume center, do it. Otherwise, be careful. Next one. The learning curve for LAP is about 19 cases. Next slide, please. And they are not without complications. They are not going to happen at the time of surgery because you are good. You may have urinary dysfunction because you need to do a post-void residue if they get fever or something. Most important is lymphoceal. So sometimes 3 months down the line, please do a scan there. So we've had people who come 6 months after that with sudden a large lymphoceal which has got the bladder perforation and a fistula there. We've had pseudoaneurysms happening in there. So if you're going to do lateral pelvic node dissection, do an ultrasound of that area to see if the lymphoceal increase in size. Okay. The thing about doing more is learning from what you have not done right. Okay. I think that is for the next slide, please. About ovarian transposition. So like 30-year-old females with locally advanced rectal cancer. Here the radiation oncologist sees a locally advanced rectal cancer, and these are bad, man. The ones which go to your vagina and require posterior exentration, maybe even signet. What do you think? You want to give them chemoradiation or no? Suppose I tell you it's signet. So locally advanced rectal cancer, 30-year-old, she is not married, not children. So would you want to refer them for laparoscopic ovarian transposition or oocyte retrieval or anything? Sometimes we don't think, you see, we think locally advanced rectal cancer and then give chemoradiation, but don't know. Or madam, what do you think? You want to give neoadjuvant therapy, why not just give neoadjuvant chemotherapy for this lady? You don't want to give radiation because she will have sexual dysfunction, ovaries might go.
So I think this is very important issue when we see the patient practically and when we discuss with the patient about the different options, and we need to talk about the different complications related to treatment. Definitely this patient should be counseled for ovarian transposition, and one of the approaches may be chemotherapy first and then followed by assessment for surgery. Yes, definitely.
What do you think, Dr. Kothari?
Yeah, so if married embryo to be made, that is number one, then transposition. Now, recently only we had one patient where, you know, they wanted to do some induction for the ovulation and all, and it was going to require some long time, and then
that's right.
As madam said, we started with chemotherapy in this patient, and
so that's exactly right. So sometimes experience wins. So if you've done it, then you know. So if you say oocyte preservation is to be done, so patient with locally advanced cancer, will you wait for all this to be done and wait for 6 weeks when she wants a stoma? So you know, so what is acceptable in the West may not be there. So think at local data. Next slide, please. So we did a lot of ovarian transposition thing. But if you give neoadjuvant chemotherapy and she responds, would you give radiotherapy additional or not? That is the question. So we put forward a trial for just giving chemotherapy for this signet, and if they became CRM free, not to give radiation. They did not agree. They said radiotherapy is a part of the study. But GRECAR4 had shown 75% reduction and they were quite okay. Trigger also might show, or prospect, whatever. Next slide, please. Okay, let's go. Next slide. So ovarian transposition very commonly done, all our trainees all over the country do it, and for the simple reason that oocyte retrieval itself, we won't have enough time there, and we have data for it. The whole idea is to have ovarian preservation, not for fertility, but if the ovaries are still there, then you can do it, and you can do oocyte retrieval later on. Problems, if you look at data itself, so we published our data over 79 months, 17% had Krukenberg tumors. So, but then you say, oh, should you do this or not? But then we looked at the data, most of these people were signet ring tumors, and all of them presented almost with peritoneal metastasis. So now we know signet ring, young female, whatever we do, okay, don't spend excess energy on them. Maybe do the shortest thing because their outcomes may not be good. I think all this rectovaginal thing extension not too bad. So, but on the other hand, all the other ones it is there, median ovarial function is 79 months, return of menses is 65%. So based on this response itself, one of the editors wrote back ovarian transposition at a high benefit, and they said they should do hormonal replacement therapy. How many of our patients actually come back and you give them treatment for ovarian ablation and they are okay with it? Not really. And spontaneous pregnancy is also not possible. That was one of the things they said about. But if you look at the local scenario itself, and they're saying if you give radiotherapy to the ovaries, that would prevent ovarian metastasis. Is there any data on it? Let's look at it. Someone has already done a trial on this. All this locally advanced rectal cancer, they did oophorectomy, and to see if it would make any difference or not. There was no difference in survival or ovarian metastasis, where the ovaries were irradiated, whereas those who went upfront surgery. This is a good one. This is by Tanya Fadok, really good one. So let's look at the next one. The next slide karenge. So now, what about this one? So ovarian transposition, there is no evidence for harm. So there was a trial in UK. They said all the nurses who went for any procedure, hysterectomy or gynae procedure, they would do oophorectomy at the same time. Okay, and would it prevent any ovarian cancer and things like that? And when they looked at the data, survival actually 3.5% mortality those who underwent oophorectomy because of osteoporosis and cardiac risk itself. So the thing about we are changing as surgeons for being testosterone driven surgeons. You still operate, but you are thinking and you're getting others to think as well. And every time you get a patient, you think, because there's a new scenario, young male, not married, young female, ovarian transposition or not. So I do more and more work, and all I get is more and more questions and fewer answers. But every question is a point for study. And that is the thing of getting people together, having multi-centric study. Thank you, Dr. Kothari.
Excellent.
Thank you so much.
Thank you so much. That was a